now we're going to talk about acute myelogenous leukemia. Because it is a acute leukemia, we will have more than 20% of blast in the blood smear. It is myelogenous leukemia, so we will not see terminal deoxyribonucleotide because those are only seen in lymphoblast, not in myeloblast. We have 7 types. We have MO, M1, MO, M3, M5, M6, and M7. MO is undifferentiated. M3 is promyelocytic, so acute myelogenous leukemia, M3 or promyelocytic leukemia. M5 is megakaryoblast leukemia, M6 is erythroleukemic, and M7 is M7 is for megakaryocytes, and M5 is for monocytes. Now, the most common would be M3, the promyelocytic leukemia, and we know that this is the translocation with chromosome 15 and chromosome 17 with the retinoic acid receptor. Remember, the neutrophils need retinoic acid receptor, the retinoic acid receptor and the retinoic acid to mature. So, because this is a acute leukemia, so there is no neutrophil maturation. Here is just promyeloblast and monoblast, etc. So, if we have the M3 subtype, the treatment is to give retinoic acid because this would promote the maturation of the neutrophils, and so we will cure the leukemia. So this is the best leukemia of the acute myelogenous leukemia. Now, for the monocytic leukemia, this presents as infiltration of monocytes in the gums, and the megakaryoblast leukemia presents with fibrosis, sometimes fibrosis of the bone marrow, but the most common is promyelocytic leukemia. Now, specifically the promyelocytic leukemia can present with DIC, disseminated intravascular coagulation, because the cells in acute myelogenous leukemia M3 contains myeloperoxidase, and this myeloperoxidase, when the cell, let's say that degranulates, can activate the coagulation cascade, and so the patient will present with bleeding and thrombosis, very, very characteristic. This presents usually in adults as opposed to the lymphoblastic leukemia, acute lymphoblastic leukemia. And the first next step when we have the suspicion of this is to take the blood smear and complete blood cell count. Now, the most accurate test would be certainly bone marrow. Also, we need to ask for flow cytometry in order to characterize the cells, at least because we want to know if it is acute myelogenous leukemia, acute lymphoblastic leukemia, even though acute myelogenous leukemia presents more in adults. Next is the treatment for promyelocytic leukemia would be with retinoic acid, but sometimes we can add arsenic. For other acute myelogenous leukemia, we give arabinoacylcytidine. This would be for induction, and we give chemotherapy. So after we diagnose acute myelogenous leukemia, we give chemotherapy. Next is we do cytogenesis, because in doing cytogenesis, we will look how likely it is that the patient relapse. If it is not very likely, then we continue with chemotherapy. If it is likely that the patient relapse, then we try to do bone marrow transplantation. Obviously, we will try that be in a patient, let's say, less than 50 years age, etc. If it is a autologous, sometimes we can take it at 70 years age, but if it is a allograft, no, until 50. So it's very important, the cytogenesis will be the best indicator of prognosis, because it will indicate if we continue to chemotherapy. That would be good because it implies that we have a low probability of relapse, And if we do bone marrow transplantation, would be because this genesis means that there is an increased risk in relapsing. Now, the patient can present with bleeding, infections, splenomegaly, and the treatment for bleeding, for example, if it's a severe bleeding, let's say in the CNIS, we need to do platelet transfusion, etc. Now, if the patient presents with infections, because in myelogenous leukemia, specifically acute leukemias, the infections are very severe. So, patient, let's say above 35 of Celsius degrees in temperature, and a very low count, let's say neutrophils below 5, absolute neutrophil count below 500 per cubic millimeter. Remember that in the acute leukemias we can have increase or decrease in leukocyte count, but what we will always have increased will be the blastic cells, and specifically we can have increasing the neutrophils or increasing the megakaryocytes or in the monoblast. We can have a lineage increase and other decrease, or at least the percentage. Now, with this, the leukemic patients are at increased risk of infection. So, if we have a patient with leukemia and infection, then it is very important to cover pseudomonas. So, we would give some, could be meropenem, imipenem, some carbapenem, or a synthetic penicillin like piperacillin, tazobactam, or cephalosporin of third and fourth generation. Could be cefepime, this is fourth generation, or ceftazidime, this is a third generation that covers pseudomonas. If the patient continues febrile for longer than 48 or 72 hours, then we give vancomycin, daptomycin, or linezolid. And if the patient continues febrile for 2 to 3 days after vancomycin, then we give caspofungin or voriconazole, because now we're thinking about some opportunistic fungi. Remember, these patients are at very increased risk of infections because the immunoglobulins are not being produced, and they are also at the risk of bleeding and thrombosis if we're talking about the promyelocytic leukemia.